Well, hello everyone, and welcome to the Briere Deprescribing Guidelines Research Team's webinar, Community Pharmacists, Partners in Deprescribing, hosted by Dr. Lisa McCarthy and Dr. Clara Korenvain. I'm Stephen Smith from the Briere Research Institute, and I'll be monitoring the chat window. Please keep your microphones muted and type any questions you may have in the chat window. And with no further delay, here are our hosts, Dr. Lisa McCarthy and Dr. Clara Korenvain.
Thanks, Stephen, very much. My name is Lisa McCarthy, and I am one of two of your hosts today. Thanks to everybody for coming and joining us, whether it be the middle of the afternoon or the early evening. I see from some of our colleagues in London, so welcome to everyone. Thanks for joining us. Just getting my technical skills sorted out here. So today it will be myself, Lisa, who is talking right now. I am a scientist with the Women's College Research Institute and a pharmacist, and also a faculty member at the Leslie Dan Faculty of Pharmacy. And it is my absolute pleasure to be joined today by Clara Korenvain, who is a pharmacist practicing at both London Health Sciences Centre and the Thames Valley Family Health Team, and who is also a master's student working with us at the Leslie Dan Faculty of Pharmacy. We're really excited today to share some of the most recent research that we've been doing in Ontario about deprescribing in the community pharmacy setting, and looking forward to hearing about others' experiences as well. So the objectives for today's presentation, the reason that you all joined us today, first we want to begin by discussing why pharmacists practicing in community settings are really key partners in the deprescribing process. I imagine by virtue of the fact that you're on this webinar, you probably are convinced of this already, but we'll run through some of that material anyway, because it helps to set the stage. And in particular, we're going to try and provide some information for anyone attending from an international context about what the pharmacy community environment looks like in Ontario, Canada, where both of these studies were done. We're going to share with you lessons learned from two research studies that use different approaches to exploring deprescribing in Canadian pharmacies. And then we're going to highlight some strategies, hopefully, that can be used by pharmacy teams to partner with their patients and local healthcare providers to champion deprescribing in their communities. I'm just being made aware that there might be an audio technical issue here with the slides. Can someone confirm for me that they can see the slides changing? That would be helpful.
Lisa, we're not seeing the slides changing at the moment.
Not seeing the slides changing. Okay, so that's a problem. Let's see here. Okay, stop. No one sees your screen now. Share. There we go. How's that?
Much better.
Much better. My apologies to everyone. So I'll just go backwards. Well, actually, that's not necessary. So all I've done is introduce myself, and Claire and I have then both been saved the pleasure of having our photos shared. So we can go back through that if you'd like. Where we want to start is really at the beginning. So why do we all care about the problem of polypharmacy? Well, the World Health Organization has recently issued their third global patient safety challenge, and they are seeking to decrease harm, severe and avoidable medication-related harm, by 50% by 2022, and that's been a global challenge that's been issued. They've identified 3 opportunities for areas of early focus, one of those being polypharmacy. And so for polypharmacy, people ask often, what is polypharmacy? Well, polypharmacy has lots of possible definitions out there about number of medications, but at our research team, we really think about it, polypharmacy is occurring when more medications are being taken than are needed, or for which the harm of medications outweighs their potential benefit. And we are concerned about polypharmacy for a number of reasons. It increases the risk of things like adverse drug reactions, drug interactions, and prescribing cascades, certainly contributes to non-adherence, and importantly has impacts for the quality of lives for people that we care for. So functional and cognitive decline is an issue, falls, fractures, and hospitalizations and higher healthcare costs are all important things. In terms of the scope of the problem, just to give you some numbers, and these are Canadian numbers here, but the numbers are very similar across the globe. In 2016, 2/3 of Canadian adults aged 65 and over were taking 5 or more prescription medications. 26.5% of those took 10 or more, and we know that polypharmacy, the risk is increased if you are over the age of 85 or you live in low or middle income neighborhoods. We also know for potentially inappropriate medications that women receive far more potentially inappropriate medications than men in Canada. And in 2013, just to get a sense of the cost of the impact of a potentially inappropriate medication, it was estimated that $419 million were spent on PIMS, or potentially inappropriate medications, which works out to about $75 per Canadian senior. And that was not including the $1.4 billion in extra healthcare system costs that come from dealing with medication adverse effects, things like fainting, fractures, falls, hospitalizations. So deprescribing is one piece of addressing polypharmacy. And many definitions of deprescribing have been proposed since the term was first coined back in 2003 by Woodward. Within our team, we define deprescribing as the planned process of reducing or stopping medications that may no longer be of benefit or may be causing harm, with the overall goal to reduce medication burden while improving the quality of life. A key point is that deprescribing is part of good prescribing, backing off when doses are too high or stopping medications that are no longer needed. And I imagine that the majority of people here today are probably with a pharmacy or at least a medical pharmacology background and are well on board with this definition. By necessity, deprescribing really does involve everyone. It involves patients or people, caregivers, healthcare providers, policymakers. And when we talk about it, typically people have a view that they can see the people, the caregivers, the healthcare providers, particularly prescribers and pharmacists. We also on our team really do feel that all healthcare professionals have a role in deprescribing, because oftentimes when we're taking away a medication, a particular symptom may still need to have some sort of strategy to deal with that. So there's a number of healthcare providers that are involved in providing non-pharmacological management of whatever symptom it was that the medication was trying to manage in the first place. So really, deprescribing is by necessity a team sport. Now what I'm going to do is turn the, hold on. Before we do that, sorry, what we want to do is now in today's webinar focus on pharmacist scope of practice in Canada. And I want to tell you about that because we have an international audience here today. And our key point here is that in Ontario, or in Canada, healthcare is primarily a provincial matter. And so we have 10 different provinces and 2 territories, all with different scopes of practice for pharmacists in Canada. And Ontario is the 5th column in. And what you might be able to see from that is that Ontario, where both of the studies that we're going to talk about today were conducted, has one of the more narrow scopes of practice, you could argue. There's certainly work, this chart was provided by the Canadian Pharmacists Association, so thank you to them for creating this. And they have undertaken a large effort right now to harmonize scopes of practice across the country, but that's probably still several years out. So we want to emphasize this point to people so that they understand the context under which both of the studies today were done. The other piece that we should emphasize is that not only are scopes of practice for pharmacists different in Canada, but the access to information that they have when they're practicing in a community pharmacy setting differs by province as well. So some community pharmacies in different provinces have access to electronic health records that might include laboratory results or prescriptions that were dispensed at other pharmacies. In Ontario, that access is really much more piecemeal. There are pilot projects in different cities and regions where pharmacists and communities are getting access to that information, but it's not definitely a standard across the province that pharmacists have that access. Now I'm going to turn to Clara, who's going to tell you much more about pharmacy practice in Ontario, where the studies were conducted.
Thanks, Lisa. So in Ontario, there are about 15,000 registered pharmacists, and more than half of those are female, and a good chunk have been educated internationally. When it comes to community pharmacy, there's over 4,000 community pharmacies across the province, and about 75% of licensed pharmacists practice in the community. So I just want to share a little bit more about a day in the life of a community pharmacist in Ontario. Next slide. Pharmacies are staffed by a pharmacist, sometimes registered technicians and non-registered pharmacy assistants. Pharmacists are in charge of checking both new and refill prescriptions against the patient's existing medications, other health conditions, and personal characteristics to ensure that medications are necessary, safe, effective, and sufficiently convenient and cost-effective for the patient. They're also responsible for supervising non-prescription medication sales and advising patients in their self-care. So in Ontario, pharmacies can also be paid for particular medication management services. I'll highlight two of them, meds checks and pharmaceutical opinions. Meds checks are one-on-one consultations funded by the government for eligible patients where medications are reviewed with a pharmacist. And if any drug therapy problems are encountered, the pharmacist can take action to solve them. That could involve contacting the prescriber. Pharmaceutical opinions are recommendations that pharmacists make to prescribers about changing medication therapy for eligible patients. If the prescriber responds, regardless of whether they accept the recommendation or not, the pharmacy gets a one-time fee. So what is the community pharmacist's role when it comes to deprescribing? Next slide. Although deprescribing is traditionally thought to be the responsibility of prescribers, such as physicians, research shows that actually physicians lack the time for this and they are missing opportunities to stop medications. So why not look to other healthcare professionals for support? Community pharmacists likely encounter deprescribing opportunities frequently in their practices during the dispensing process, and they may also come across deprescribing opportunities while reviewing medications for meds checks. However, much like physicians, community pharmacists also likely face challenges when it comes to incorporating deprescribing into their practices. Pharmacists have many competing demands on their time and may not be able to focus enough on deprescribing to make a significant impact. Community pharmacists in Ontario also typically don't have access to a patient's medical history. As Lisa has mentioned, there's been some information access limitations, and they might need this information to make deprescribing recommendations. The current literature lacks studies directly describing community pharmacists' actual roles in deprescribing in their practices and how these roles can be enhanced. The first study we're going to talk about today aims to further our understanding in that area by focusing on two research questions. How do Ontario community pharmacists describe their involvement with deprescribing, and what are the opportunities for enhancing this involvement? The aim of this research is to inform the design of interventions that are targeted specifically towards enhancing community pharmacists' involvement in deprescribing. To address these questions, I used a qualitative study design featuring telephone interviews. So participants had to have worked full-time at an Ontario community pharmacy for a minimum of 1 year. I also recruited pharmacists that are diverse with respect to three characteristics that we hypothesized could influence their practice based on literature review. So those were their years of experience working in a community pharmacy, their employment position, and whether they worked in an urban or rural setting based on postal code or their descriptions. Participants were recruited through convenience methods, so mostly by reaching out to the research team's contacts, but also by posting on social media. Some pharmacists were referred by existing study participants in a snowball fashion. I conducted semi-structured interviews with our participants. The interview guide incorporated concepts from the behavior change wheel, which is a conceptual framework from implementation science that links causes of behavior with interventions for change. The guide incorporated the three causes of behavior identified in the wheel: capability, opportunity, and motivation. Test interviews with non-study participants were used to refine the interview guide, and then interviews were audio recorded and transcribed verbatim for analysis. To make sense of the interview transcripts, I used a coding process to group together sections of text with similar meaning. I used the behavioral causes from the wheel as sensitizing concepts during coding to ensure nothing was missed. And then I created themes by grouping together the codes that had related meanings. In total, we had 17 participants at the end of the day, with a pretty even split between males and females. Sorry, next slide. And both got their pharmacy degrees in Ontario. 3 main themes were identified, and I'll explain the key highlights of each in the coming slides. The first theme is about what our participants told us about their understanding of what deprescribing is. Most participants were not familiar with the term, but familiar with the concept to some extent. So all were involved with deprescribing in one way or another in their practices. However, how they conceptualized deprescribing differed in a few important ways, and I'll focus on 2 key points. The first is what needs deprescribing. Some acknowledge that any medication can become inappropriate because a patient's needs may change over time. Others thought that pharmacists should assess only certain medications typically considered potentially inappropriate, such as those on the American Geriatric Society Beers list for older adults. Some participants thought that deprescribing is something that should ideally be considered each time a medication is dispensed, although they acknowledge that this doesn't always happen in practice. However, some believe that there are medications which are meant to be used indefinitely unless some sort of intolerable side effect comes up. The second point I have is about who is responsible for deprescribing. Many participants conceptualize deprescribing as something that is controlled by the prescriber. These participants often felt that making efforts towards deprescribing may not be the best investment of their time and limited time and energy. So for example, if they could not get in touch with a patient's prescriber about a deprescribing recommendation, or if they assumed based on past experience that the prescriber would disagree with it, then they felt that there wasn't much else that they could do. The second theme is about how information access influences participants' sense of responsibility for deprescribing. This figure represents how the more patient information that participants had on one side of the balance, the more their willingness to make deprescribing recommendations went up. But this also worked the other way. When participants felt they lacked sufficient information to assess a specific patient's medication therapy, they were less willing to take on the responsibility for making a deprescribing recommendation. For example, participants felt they often didn't know the rationale for using a medication in the first place, or necessary laboratory test results that would help them decide if a medication is needed or safe. But when participants had access to information that they felt others, like prescribers, did not have, they described feeling a sense of responsibility to act by sharing this information or making a recommendation. To illustrate, participants felt that because of their frequent contact with patients, they often knew about their responses to medications, their personal circumstances that could affect medication use, etc. All information that they felt prescribers may not necessarily know. So they felt a sense of responsibility to make sure that information is relayed to prescribers so that it can be used for the benefit of patients. The next theme is about what participants told us about the tensions between their business and health professional roles. The health professional role they described as including addressing drug therapy problems, such as making deprescribing recommendations. They described the business role as encompassing tasks that were necessary for a pharmacy to run as a business, such as preparing prescriptions for dispensing. For participants, these roles were in competition with each other because pharmacists have limited time, and participants actually unanimously preferred the health professional role, but all of them experienced pressure to prioritize the business role because a high volume of dispensed prescriptions was described as generating most of the pharmacy's revenue. This pressure affected everyone regardless of their position. And the pressure was not alleviated by reimbursement mechanisms such as meds checks and pharmaceutical opinions. They were described as insufficient to offset the costs of providing the care and losing out on the revenue that dispensing the medication would have provided. And because meds checks and pharmaceutical opinions are also part of the healthcare professional role, some participants had a hard time prioritizing them in practice as well. Deprescribing was, however, prioritized higher when patients brought up concerns about their own medications. Next slide. The participants in my study provide examples of some of the challenges that typical Ontario community pharmacists may face when incorporating deprescribing into his or her own practice. So what are the things that we can take away to improve our own practices? Well, the first is, as community pharmacists, we can start with deprescribing, perhaps for non-prescription or over-the-counter medications. Participants felt more empowered to affect change in OTC medication use. We can also partner with a few prescribers in our area that we have good relationships with to find out where our services are most valuable when it comes to deprescribing in that particular partnership. So is it in monitoring? Is it in identifying potential opportunities for deprescribing and flagging that for the prescriber? The point is really to start small. And the other thing is to consider empowering your patients, getting them to drive the conversations. This helps not only get prescribers on board, but also helps pharmacists prioritize deprescribing over other tasks in the pharmacy. And there are existing tools to help with this, such as the Empower brochures available on deprescribing.org. Now, I'll hand things back to Lisa, who's going to tell you a little bit more about the second study today.
That's great. Thanks, Clara, very much for sharing some of the fruits of your master's thesis with us. Really appreciate that. Now I'll take the reins and describe to you a second study that we wanted to share with you today. And I want to acknowledge the team behind the study. So certainly, actually, there's a lot more people than are just listed on the slide. These are the study investigators, but I am presenting on behalf of a research team led by Dr. Barb Farrow. And we are going to refer to this study as the Catalyst study for short. And one of the things we thought might be helpful at this point, because we're switching gears between studies, is to really kind of try and highlight the similarities and differences between the work. So what we want to say is that both of these studies, while using different methods and with different objectives, ultimately we're aiming to understand how to help community pharmacists become more recognized partners in deprescribing. What differed? Well, there were lots of things. So Clara's work, her research questions were really focused on the what is currently happening. And I'm acknowledging that I'm very much oversimplifying all of this for us right now. So qualitative interviews looking at what is currently happening, whereas in Catalyst, the next study I'm going to talk to you about, really was looking at when you equip pharmacists with a variety of tools, resources, and training, what's the best way to go about incorporating deprescribing into the community pharmacy practice. In terms of the participants, Clara's study had a broad range of participants, all practicing in community pharmacy, but all with different levels of, I guess, an understanding about what deprescribing was. Whereas in Catalyst, what we did is we actually used 4 pharmacies where you could describe the teams as motivated to incorporate deprescribing into their practices. In terms of the objectives, very similar to the research questions, but Clara was keen to understand the current state and what are the opportunities to enhance deprescribing. In Catalyst, what we were doing was trying to create some best practice examples and work with pharmacies to equip them with tools and resources to and the expert advice to help them do this in their practices. So quite different in terms of their motivation. And in terms of the study design, as Clara explained, she used telephone interviews. Catalyst was a mixed methods, qualitative and quantitative study where we used case studies, ethnography, we employed an active advisory group, and also used a quality improvement approach. So you'll see that more as we go. But to begin with Catalyst, Catalyst was founded or grew out of work that our research team had been doing over the last several years to create evidence-based clinical practice guidelines for deprescribing. And likely if you're on this webinar, you're familiar with this work. So our team over the last 5 years has created 5 different, to this point, medication class specific deprescribing guidelines that are all available open access. So meaning free of charge, that you can get to from deprescribing.org, and you see that the classes of medications that we've worked on there. What Catalyst wanted to do in this project was to see what would happen if we equipped community pharmacists with existing tools and resources like these guidelines and the knowledge products that we've created out of them. So what are some of these guidelines, tools, and resources? Well, one of the key, most popular, I think, tools and resources that we've created are deprescribing algorithms for the different medication classes. So on this slide, I'm showing you an example from the benzodiazepine deprescribing algorithm. And on the front page of all of these algorithms that look quite similar, although the content is quite different, we run through a decision support type of tool for clinicians around who to consider for deprescribing, when to, and then how to approach that. And on the flip side of that is particular information specific to the medication class around tapering or alternative strategies that can be used, pharmacological or non-pharmacological, and kind of handy tips. All of these guidelines and algorithms have been put together by clinicians and researchers, chosen specifically for their expertise in particular therapeutic areas, and have been endorsed by several organizations, far more than I could actually list, and specific to each medication class. We've also created a series of YouTube videos that present whiteboards about how we develop the deprescribing guidelines and actually go through, for each medication class, how to apply the algorithms and the recommendations from the guidelines to specific patient cases. And so all of those are available on our YouTube channel. through deprescribing.org. I believe you can get there, or perhaps Stephen can post the link for us after. So that's to give you a flavor of some of the deprescribing guideline-focused tools and resources that we had available. And then in Catalyst, what we aimed to do was, if you give teams training tools and help them with implementation strategies, look at if and how deprescribing practices can be integrated into the daily community pharmacy workflow. In terms of the participants, we had 4 eager community pharmacies, 2 in Ottawa, Ontario, and 2 in Toronto, Ontario. All of them varied with respect to the ownership model, the prescription volume ranging anywhere between 60 and 220 prescriptions a day. They had a variety in terms of human resources, anywhere between 1 and 4 full-time pharmacists, number of employed pharmacy technicians, and some also had pharmacy students that were regularly at the site. All of the pharmacies provided what you could call professional pharmacy services in addition to dispensing. Everyone did meds checks. 3 of the 4 did compounding services. 3 of the 4 offered compliance packaging. We also created strategically through this project an advisory group that built off members of the Ontario Pharmacy Evidence Network Knowledge User Advisory Committee. We had representatives from 3 of our national health insurance payers, as well as representatives from community pharmacy organizations and chains. We had the representatives from the 4 community pharmacies, as well as the project co-investigators, all part of this advisory group. And the purpose of the advisory group was to provide direction and strategic input on how to incorporate deprescribing into the existing workflow processes within the community pharmacies. So there were 3 key objectives in Catalyst. First was to really build capacity to integrate deprescribing into the community pharmacy practices by training, providing opportunities to practice implementing the tools and resources, and really hone the workflow strategies used by the pharmacies. We were keen to quantify and qualify the deprescribing activities and processes that were associated with guideline use. So to quantify the time needed and articulate things like the number of pharmaceutical opinions and meds checks that could be done, to understand what kind of educational materials and other resources needed to be developed, and the cost of doing so. We also wanted to understand the facilitators and barriers that arose. And finally, we were hoping to culminate with a draft business model based on the analysis and the synthesis of the results. In terms of the data collection, there were lots of components to Catalyst. So we collected a lot of quantitative data, you could say, about deprescribing opportunities, the actions and the outputs that arose. We also uniquely had particular observation periods where qualitative researchers trained in ethnography actually went to the pharmacies to observe the processes that were going on. And every pharmacy then engaged in between 2 and 3 plan, do, study, act cycles. So they chose what activities they were going to do, had an intense period where they implemented those, and then we sent the ethnographers in to observe, and all of that information was reviewed by the advisory group, who then was able to provide feedback to the pharmacies about how we might tweak the processes that we use. So this really did allow the team to appraise and accelerate the improvements in the processes, summarize key findings, and really identify the facilitators and barriers. That's what Catalyst was about. Now, in terms of findings, what we did find is in Catalyst that did focus on community pharmacy sites. Deprescribing was feasible at all of the sites that were involved in the studies. The practices and the approaches that they used did differ by site. Each pharmacy created resources and materials at their sites, despite having been provided with a lot of them. Everybody wanted to kind of customize them and tailor their processes for their sites. That makes sense. All sites were able to identify individual and common goals, and they developed unique kind of community workflow models for deprescribing their work at their sites. What we found were some commonalities among how they approached the work. So first, all 4 pharmacies undertook capacity building activities, and that was steps to train their staff, train their pharmacy teams, and undertook steps to identify patients that might be eligible for deprescribing interventions. They all thought about what were the preliminary interactions that were going to happen with patients. So primarily this focused on how will supporting staff, pharmacy students, pharmacy technicians, front store people work together to help patients that were interested in deprescribing connect with the pharmacists that could help them do that. And that happened either in-store or by phone outreach. Then there was a number of things that happened in terms of detailed interactions with the pharmacists, particularly with respect to meds check, and then follow-up and monitoring. So how did they reach out to prescribers, and everyone developed a process for doing that and monitoring patients' performance. In terms of facilitators, so what did we find that worked? Well, a number of things actually. All the pharmacies really did find that deprescribing was a team sport and that a collaborative team approach was really necessary for success. Motivated and supported staff and students were really key in terms of helping patients to connect with pharmacists. The staff did report that they found it helpful for on-site educational initiatives to take place actually within the pharmacies. All the sites found that developing standard templates for pharmaceutical opinions was particularly helpful in terms of their workflow and saving time. And people that use strategies to enhance patient awareness and education regarding the risks and options to reassess found that was a particular facilitator. One pharmacy actually had a creative campaign that was pretty low tech. They used a sandwich board outside their pharmacy to invite people to participate or to approach them about deprescribing conversations, and that actually was quite a successful strategy for them. In terms of barriers, some of these barriers are consistent. I do a lot of pharmacy, what you could call pharmacy practice research in the community pharmacy setting, and a lot of these barriers are things that we find that arise kind of across different implementation projects. Certainly our pharmacies struggled with competing demands on their workload. You know, that everyone grappled with the issue of staff turnover and training new staff. We heard a lot about inadequate compensation models, as Clara alluded to with her work. And we talked about some challenges in terms of finding space for deprescribing discussions. In terms of communications, I apologize for that notice that's going up there. I'm just trying to figure out how to turn off my Dropbox here. Back to that. Communication, certainly there were challenges in terms of delays and lack of response from prescribers when they sent deprescribing recommendations. And with patients, some of the barriers were that patients experience uncertainty or resistance to change. And there were some challenges around patients receiving medications by delivery or using multiple pharmacies for dispensing their medications and sorting out the roles for pharmacists and for deprescribing in those situations. In terms of the key to successes, really approaches to draw patients into the pharmacy were very successful. I mentioned the sandwich board. Other pharmacies use notices on their websites. One pharmacy did a webinar. Somebody placed an ad in a newspaper, all inviting people to come in and have those conversations. They really did train all staff to field questions. One pharmacy in particular really put an emphasis on training their front staff to ask people key questions that then led people to be linked up with their pharmacists. Using standardized templates did help in terms of the completeness of the documentation, but also in saving time. Faxing evidence or algorithms that the deprescribing algorithms for the guidelines that have been created along with pharmaceutical opinions was a successful strategy in a couple of sites in terms of getting their recommendations uptaken. And engaging students and other support staff to share the workload of deprescribing was another key success factor. In terms of the business model development, we undertook a number of strategies to try and develop a business model. So in each pharmacy, there were iterative observation periods, as I mentioned. We also did rapid analysis cycles after every PDSA and had 3 key advisory discussion meetings to review those PDSA cycles and provide input to the pharmacy as they compose their next plan. All the data was reanalyzed independently by 2 members of the project team. Outside of that, we took a lot of work to try and integrate the quantitative data into the qualitative analysis. There was a business model and a canvas that was designed and presented to the advisory group, and have gone through 2 rounds of feedback on that. I can't actually share the actual business model canvas with you because it's pending publication. But what a business model canvas is a visual chart that has different elements that describe the value proposition, the infrastructure, customers, and finances. So it actually has 9 key building blocks for a business model and identifies things like key partners, key activities, value propositions. And so you can look to having that at your fingertips as soon as we can get it released. I will say that the work was not able to culminate in a comprehensive business model, as one might expect. There's a number of challenges around that I'll talk about in a moment. So in terms of lessons learned from Catalyst, well, the sites were all diverse and distinct in nature. And that really helped us understand that there's not going to be a one-size-fits-all approach to implementing change in community pharmacy for deprescribing or for anything else. Deprescribing was feasible at the community pharmacy level in all of the sites that we worked with, admitting these were motivated sites. What we found were key was sites that were flexible in terms of their planning and willing to set goals. This was really important because when we reviewed the 2 to 3 PDSA cycles that each pharmacy did, what they originally thought they were going to do and then what actually worked in their practice realities really did change over time. The other thing is that the business model and the canvas that we created were really based on small sample sizes, and they offer insights into our process, but are certainly we're not close to having a testable model with revenue indicators at this point. So those were important lessons learned in terms of catalysts. Next steps, we're hoping to conduct a larger demonstration study with 40 to 50 sites. We are providing ongoing support to the pharmacy sites that want to continue and build on the deprescribing measures. And our team has had some complementary funding to develop more tools and resources to support integration into practice. We have recorded video testimonials from some of our pharmacists to describe what worked and didn't work in their pharmacies. We're creating an app to help people develop or help people implement the guidelines in their practice. I'm going to tell you a little bit more about that now. So we are getting to take-home messages, and then I look forward to addressing. I can see multiple questions coming up through the chat window, which is great because I appreciate the engagement in the topic. So our key takeaways are this. So there are many tools and resources that exist. The majority of them are showcased on deprescribing.org. The guidelines themselves, the decision support algorithms, the whiteboard videos. We are, as I mentioned, in the process of developing an iPhone app for the different deprescribing medication classes and the algorithms. So that'll be coming soon. Stay tuned. The other thing I would tell you is that our team is quite active on social media, so it's another great way to connect to you. So please join us on Facebook and Twitter. There's a series of monthly Twitter chats that are happening that we hope that people become involved in, and certainly is a good way of staying tuned for kind of future webinar announcements. What I'd like to do next is show you, I promised you some resources for people to take away into their practices, and so that's what we wanted to share with you next. So all of these tools and resources are available through deprescribing.org, and a number of them have been created by our partners at the Canadian Deprescribing Network. So they're online. You'll find things like a fact sheet for healthcare providers that can be used in practice about deprescribing generally, but also a number of kind of patient education materials that are great for promoting and getting patients to initiate conversations around deprescribing. So those are available to anyone that would like to use them, and they can order those through the Canadian Deprescribing Network. There's also, and Clara alluded to them, the Empower Research Program has created a series of patient education materials that help patients to wonder about whether they are appropriate to have certain medications deprescribed. So there's brochures for things like anti-inflammatory medications, antipsychotics. I believe they've also done medications for allergies, sleeping pills, pills for acid reflux like proton pump inhibitors. So all of those things are available online, free of charge. They've also created pharmaceutical opinion templates. These were developed to be used in the province of Quebec, but they could certainly be adapted for other provinces or other jurisdictions where similar types of programs exist. And these were co-designed with prescribers as well as pharmacists to try and include the content and the level of recommendations that were desired by those groups. So I encourage everyone to look there. There's also the MedStopper tool. If you're not familiar with MedStopper, provides recommendations for or helps people to prioritize when you've got a patient with a lot of medications, which medications to stop and in what order. And also there's a number of materials that have been created through our collaborations with Choosing Wisely Canada. And so those are some of the other things that are going on within Canada. To wrap it up, and I look forward to moving to the question part of our program, what we want to say is that community pharmacists are important partners in deprescribing who can make really unique, important contributions. We know that what works for each community pharmacy and pharmacist probably differs, but there's much to be learned from sharing experiences. And we also recognize that there's much more work to be done toward refining the business model for community pharmacy. And so that starts with data collection, and if interested, please reach out. We also recognize that there are a number of other settings, primary care, healthcare teams, pharmacists embedded in hospitals. So there's a number of other, there's lots of professions beyond pharmacists, but also within the pharmacy community, lots of other places where we could pursue deprescribing efforts. This was just one particular snapshot, so we want to acknowledge that as well. Anyone that wants to connect with us, there's my contact information. I'm Lisa McCarthy, and Clara Korenvain was presenting to us earlier. And then again, just more about how to get hold of the deprescribing research team. And lastly, before we move on to the question and answers, there's a number of funders that have really supported the work of the deprescribing guideline research team over the last several years. And so we put their logos here. I won't list them all, but certainly an acknowledgement and a sincere thank you to all of those people. And now I guess we can move on to the question part of things. Stephen, how do we want to do this part?
Well, first of all, thank you for the excellent presentation. I will be reading off the questions from the chat window, so I'll be doing the moderation, and then you two can do the answering. We have quite a few, so we'll try and fire through these as fast as we can. And so our first question is, can you comment on the recruitment challenges for the Catalyst study, as well as the generalizability of the results, such as the motivated minority versus the reality of the majority pharmacists in community practice?
Okay, so the first part of that was about the recruitment challenges. You know what, we were looking for 4 kind of motivated pharmacies, and actually that wasn't a huge obstacle to find. Certainly, as we've developed our guidelines over the last several years, there's been a number of pharmacists that have talked about wanting to become engaged with the work, and so we were able to do that. Certainly, there's always the balance when you're doing research about working with the motivated few versus kind of the broader spectrum. And in Catalyst, because of the intensity of what we were trying to do and understand, we opted to start with the best practice examples to really learn what we could and understand the challenges that were encountered in those sites where they were motivated, and that wasn't necessarily a challenge. And so that was the justification in Catalyst for starting there. I think what's nice about the work that Clara has done is it provides kind of a snapshot of kind of a broader pharmacy picture. And so I think the 2 studies taken together provide us a sense of ways forward in terms of engaging kind of a broader audience in community pharmacy. Clara, did you want to add?
No, I think that was great. Thank you.
All right, well, our next question is, are there any pharmacists working within medical practice, and would they be able to deprescribe?
So certainly a great question, and probably from one of our international partners. We do actually have in Ontario and across Canada actually a number of pharmacists that are embedded in what we call our primary care or our family health teams. And the scope of practice around who actually legally can deprescribe is interesting, but a number of those pharmacists have engaged in a lot of work around deprescribing. We know that having face-to-face interactions, or the opportunity for face-to-face interactions with prescribers, can make a huge difference in terms of getting your recommendations accepted and your credibility and all of those things. So certainly there's a number of people doing work in that area. So yeah, we do have that happening, although it wasn't the focus of the research studies that we presented today.
All right. Did you have any resistance from patients who felt their family practitioners should be doing deprescribing did you have any resistance from patients who felt that their family practitioners should be doing deprescribing or managing their medicines, or concerning that prescribing or deprescribing wasn't coordinated?
Clara, do you want to talk about that piece of things?
Absolutely. So my study didn't focus on patients per se. It focused on what pharmacists saw about how patients affected their deprescribing efforts. So from their perspective, some pharmacists did talk about how particular patients expected that prescribers would be the one to deal with deprescribing, and they were a little bit resistant to pharmacists getting involved. So this kind of varied on a spectrum. Some patients, I would say those are the ones who just didn't see pharmacists in kind of an expanded role. So they saw them as sort of the medication dispensers and didn't really understand the role that pharmacists can have in medication management. There were others who sought a little bit more of a coordinated approach. So they weren't super comfortable with pharmacists making a recommendation directly to the prescriber. What they asked for was, you gave me a lot to think about, let me take this to my prescriber by myself, and I want to drive that conversation, and that was fine. So there was kind of a variety of perspectives, although we didn't exactly focus on that.
All right, great. Is the pharmacist compensated for a successful deprescribing intervention?
So right now in the community setting, there is no actual compensation for the outcome of any particular recommendation that's made. Clara, did you want to add anything to that?
Yeah, originally we thought that perhaps through medication reviews, which in Ontario are reimbursed as meds checks, perhaps pharmacists can use those to find deprescribing opportunities and therefore get compensated for at least some piece of it. And same with the pharmaceutical opinions, that maybe if a deprescribing recommendation came out of something that for eligible patients at least, they could get a one-time fee for that. But what we found is that pharmacists don't, or at least our participants didn't necessarily see it that way, or they thought that, you know, the compensation wasn't exactly adequate. And I did mention that a little bit in the presentation. So directly, no, there is no compensation mechanism. Indirectly, maybe, but there's some work to be done before that can be used effectively, I would say.
The other piece on that, I would say, and this is not at all from the deprescribing work, is that there's been some work done about pay for performance in the community pharmacy setting in Canada by Sherry Lynn Hubel, who's currently at the University of Waterloo, but it was done in the context of while she was in Alberta. And there's been some mixed reactions, particularly in the province of Alberta, to community pharmacists and their willingness to embrace kind of pay for performance or success-based compensation. And so anyone that's interested in that, I encourage you to look to that, but no, nothing in the deprescribing world in Canada that I'm aware of.
Okay. How generalizable do you think your results are to community practice across Canada?
Which I guess I would want to ask back which study and what do you which study in particular. I think Clara, do you want to comment on the transferability of your findings, and then I can talk about Catalyst? Absolutely.
So we tried to get as much as possible a diversity of pharmacists in characteristics that we thought would be important for deprescribing. Having said that, probably a good majority of them came from GTA and very kind of geographically close areas. So we have to keep that in mind in terms of generalizability to the whole province, let alone the rest of Canada. And then we talked, Lisa mentioned in the beginning, about how scope of practice differs by province. So there's issues about access to information, which differs by province, which was actually a big theme that came out in my work. You know, that alone would be a little bit of a limit to generalizability. Having said that, there's things that we expect to be pretty constant, like you know, competing demands on time is probably something that every pharmacist faces to some extent across Canada, et cetera. So it has to be taken in the context. The results have to be taken in context of where they come from, but certainly some things other provinces can learn from.
All right. Do you have opportunistic deprescribing when discussing compliance that is poor?
I can probably take that one, Lisa, as well. Yes, so I saw my participants mention some situations where that was what I meant when I talked about patients bringing up concerns about their medication. So sometimes it came from the patient, or sometimes it was the pharmacist initiating a conversation about compliance, and that brought up a concern from the patient. And then that started a conversation about some questions about whether that medication is still needed or safe or what have you.
Okay. And are there plans to research in a collaborative manner with pharmacists embedded in primary care teams?
I think that's something that certainly there's there's a lot of interest in doing that particular work. It's a different vein than what we were talking about here, which was really pharmacist community in the community traditional kind of retail type of setting that people talk about. But certainly, if there was somebody that was particularly interested in kind of forwarding that through, then please reach out either to any members of the research teams that you saw listed there or myself directly, and I would love to have those conversations with somebody.
And can I just add to that? So I also practice in a family health team, and there's talk of doing a very small pilot project about trying to do just that, and involving community pharmacists as well, actually in partnership. So we're trying to do something with it.
Okay. And how are the resources for patients publicized, and particularly are they encouraged to ask for medication review from their prescribers and pharmacists?
That's an excellent question. So the Canadian Deprescribing Network has embarked on kind of strategic communications campaign for members of the public. That's involved a lot of outreach through the media in terms of key outlets and social media channels and things like that. So they're really looking after a lot of those types of things. But from a community pharmacy perspective, I'm not aware of there having been a coordinated approach to really encouraging people to do that for the purposes of deprescribing. I think individual partners in different chains have encouraged kind of medication reviews and talk to your pharmacist, and certainly some of the advocacy groups at the national and provincial level have tried to initiate some of that work. But certainly there's more that definitely could be done in terms of getting the word out.
All right, and I think this is regarding the Catalyst study, but when can we expect to see the findings published?
Well, that's an excellent, there's always lots of variables in terms of when the results will be published. Certainly, if you watch the Twitter sphere, as well as Facebook and our deprescribing.org site, as soon as we have the permission to go ahead and to post those things, they'll be made available to people. We are in the process of finishing up manuscripts now, and then they'll be submitted. They have to go through a peer review process, and so we're hoping certainly by the end of the year that stuff would be available. If there was a particular piece that anybody needed access to earlier, then please reach out to us, and we will certainly see what we could do about sharing for particular purposes with individual people.
Great, and we still have just a little under 10 minutes left in the webinar presentation. If anyone has any further questions, please post them in the chat window. We'll keep the line open for at least another 4 or 5 minutes, depending on how frequently the questions roll in.
I'm just looking through some of the other comments and seeing some really interesting kind of thoughts about things that are coming up here. So Nina, for example, from the UK, is talking about the potential disincentive to deprescribe as reimbursement is currently for items dispensed. Clara, do you want to kind of speak to that point, because I know that's certainly something that came from your work as well.
Sorry, would you repeat which one that was about? Which comment? I'm just trying to scroll through them all.
Oh yeah, certainly. So Nina Barnett is a well-known pharmacist in the UK, and raises the point about the potential disincentive for deprescribing, because reimbursement is certainly is currently based on volume or items dispensed, and so that was actually something that you saw in your work as well.
Absolutely. Correct? So we did see an awareness of that among our participants. Our participants were adamant about asserting that this would not be, on a case-by-case basis, a reason for them, or even a consideration for them to, not recommend deprescribing something that they felt really needed to be deprescribed. Where it maybe fell in is the prioritization piece. So it was about, spending time, staff time and effort when there was all this dispensing lined up to do, spending that time towards deprescribing interventions was a little bit difficult to justify in the kind of current community pharmacy environment. So that's it. It came into play definitely, but in sort of a more subtle way.
And then we have a few more questions here from the audience as well. And one person asked, did the idea of patients paying out of pocket for deprescribing come up? It would potentially save them money in the long term.
Yeah, I think it's a really good point, and I believe one of our pharmacies has followed up kind of on that opportunity for having people pay for those consultations out of the Catalyst project. We didn't specifically seek any kind of reimbursement opportunities directly from patients through that particular project. And actually what we were fortunate to have on our advisory group was actually 3 representatives from private health insurers who were watching, certainly kind of keenly interested with that exact lens about potential cost savings. And so I think one of the challenges in our current health system with advocacy around remunerating pharmacists for deprescribing efforts is back to the traditional setup in Ontario, at least, where pharmacy and pharmacy services are funded through the drug budget, not necessarily through a more global kind of healthcare budget. And so savings realized in one particular silo or sector of the healthcare budget does not necessarily translate into meaning in terms of saving on the drug budget. And that's certainly a limitation that I don't have the answers to. There's a number of smarter people than me kind of working on how do we move that particular piece forward at the provincial and national advocacy level. But I think absolutely there's a keen, motivated group of patients that might be motivated to pay for deprescribing, and so that's certainly something worth exploring with people. But ultimately, you would hope that we could also engage private insurers and the government in this work.
All right, great. And someone asked, when did the deprescribing movement really take off in Canada?
Oh, that's an excellent question. It probably kind of depends on who you talk to. I could say that our work in terms of the Briere Deprescribing Guidelines team, our first funding was in 2013, although Barbara Farrell, who leads that team and is credited with a lot of the work, particularly in pharmacy and deprescribing in Canada, has been working on challenges related to polypharmacy and potentially inappropriate medication use, probably throughout almost her entire career, she would probably say. And so I think, though, that we've seen really interesting traction since 2013, the last 5 years. The Canadian Deprescribing Network formed in 2015, and so we've definitely seen a huge kind of takeoff in the last 5 years in terms of the work, and hopefully that'll just continue to expand, particularly in light of opportunities like the WHO Patient Safety Challenge.
Is pain management also a topic of deprescribing?
Well, I think certainly there's a lot of opportunity for deprescribing in terms of developing. We've had discussions about developing guidelines for opioids, and there's discussions about guidelines for antidepressants and potentially anti-epileptics that sometimes get used in neuropathic pain, and what are the roles around deprescribing in those situations. And I think our team would love to be able to take on development of guidelines in those areas. One of the challenges is that our team uses a particular process for developing the guidelines themselves that is quite labor intensive, but is necessarily so because we are using a level of rigor that uses the GRADE methodology, which is recognized kind of across the world as a high standard for synthesizing evidence for guidelines. And so to do that, it becomes costly and labor intensive. And so we're certainly interested in developing more guidelines. It's finding the funding to be able to support that work. But absolutely hot topics. There's lots of them that are out there, and opioids are a big one on the list.
And what do you think about the terminology of deprescribing and how that might be interpreted by patients? Perhaps it is a medicines review we should be encouraging with deprescribing as a part of this?
Yeah, you know what? I think you're going to find. I'm laughing a little bit because we talk about this one a lot. There are some people that are real proponents of the term deprescribing, because what it does is it labels something. So certainly, the concept of stopping medications when they're no longer needed or when the harm exceeds the benefit is not new, particularly if you've been trained in like the model of pharmaceutical care. So the concept isn't new. What deprescribing did was kind of let people mobilize around a particular word for it. And so I have not always been a big fan of the word deprescribing personally. And certainly with patients, I know sometimes that it can be a challenge to try and get that word understood, and that's been a challenge that the Canadian Deprescribing Network has grappled with. On the flip side of that, it has been gaining increasing traction, particularly in the clinician world over the last 5 years. If you look at things like even the number of like PubMed citations and Google citations, it's really exploded with the word deprescribing. And so I think regardless of whether we like it or not, it's a term that's here to stay now. And so that's kind of my take on it and why I use the term in the work that I do.
All right, we have one last question discussing about how deprescribing is being promoted, and it's curious is deprescribing being promoted on television at the moment?
Not that I'm aware of. Clara, have you come across anything in terms of the TV? And certainly there are news clips that come up, and some of the investigators get interviewed from time to time, but that would be like on the evening news type of cycle. I'm not aware of any kind of coordinated advertising campaign. How about you, Clara?
Absolutely, I'm not aware of anything.
Yeah.
All right. Well, and that will bring us to the end of the question and answer period and the end of our webinar. Thanks everyone for attending, and thanks to our hosts, Dr. Lisa McCarthy and Dr. Clara Korenvain. Be sure to fill out a webinar evaluation while the content is still fresh in your mind. Recordings of the webinar will be available on deprescribing.org and YouTube. The Breer Deprescribing Guidelines research team is hosting webinars throughout the summer. A link to more information and registration is available in the chat window. Follow us on Twitter at Deprescribing and like us on Facebook at deprescribing.org for regular updates on the deprescribing movement. Once again, thank you for your attendance, and we hope you join us for our next webinar, Non-Pharmacological Supports for Youth, hosted by Dr. Jaden Webb.